Sound Life is a one-stop hearing healthcare center that focuses on diagnostic and management of hearing disorder. We offer a complete range of hearing products and solutions for both our adult and children. We strive to provide professional and personalized hearing services by our trained audiologists. In Sound Life, we are all certified audiologists, where we follow the best audiological practice in order to help our clients to rehabilitate their hearing-related difficulties. We carry different brands of hearing aids and few other health products to fulfill the requirement and need of our clients.
It's amazing to see how much joy one can achieve through better hearing.
My life is much better now with my new pair of hearing aids. I can FaceTime call to my children.
My hearing impairment improved tremendously, and I'm very satisfied with that.
Here at Sound Life Hearing, we are focused not only helping you to hear better, we help you through all the aspects of your hearing health. If you have any questions about your hearing, contact us and schedule an appointment today.
Hello everyone. Good evening. Welcome to our Facebook Live session, Discover New Speech Development Strategies, Navigating Options for Children with Hearing Loss. My name is Karen. I'm the Business Manager for Cochrane Malaysia. Thanks for joining us today on the Facebook Live event on a Friday evening. I'm thrilled to be here with you today to delve into an important topic that impacts countless families worldwide. So communication lies in the heart of human connection, yet for some, the journey to articulate thoughts and express oneself can present unique challenges. So today we are embarking on an exploration of innovative strategies aimed at unlocking the full potential of speech development. So we will now kick off this session with Ms. Aliyah Cheng, who is the Chief Audiologist from Sound Life Hearing. She will shed light on the significance of long-term hearing loss management. Following that, we have Ms. Shiro Tay from Speak to Me, specialist speech language therapist who has attained the cert in auditory verbal therapy. She will provide her expertise and topic that's close to her heart on the effective speech language development in children with hearing loss. Last but not least, we have Ms. Oka Ping, who is also from Speak to Me, specialist speech language therapist specialized in pediatric feeding and swallowing. She will provide us with some tips on recognizing red flags and warning signs of oral motor, feeding, and speech clarity. Thereafter, we will open to the floor for a Q&A session and address as many questions as possible, followed by a quiz. And we are handing out 3 Grab vouchers worth 20 ringgit. And just a quick tip for all of you, do engage with us on the comment box. Feel free to say hi, drop your message or question. We'll collect them and we'll address them as much as we can during the Q&A session. So for all of you who have joined us today, be it you're a parent or you're individual or even you're an educator searching for effective teaching methods, or you're looking for a child's language milestones, improving their speech development, this is a session tailored to offer valuable perspectives and actionable tips. So sit back and engage with us through the comment session, and let's embark on this enlightening conversation together. And I would like to now invite Aliyah, Miss Aliyah Cheng from Sound Life. She's the Chief Audiologist of Sound Life Hearing in Malaysia. And we'll kick off the topic with some context before we go into the speech therapy topics, right? So let me see. I will probably introduce the other speakers in the later session, okay? I will have Aliyah turn on live first. Hi, Aliyah.
Hello. Hi, Karen. Hi. Hi, everyone.
Hello. So thanks for joining us this evening with our audience. So we want to understand maybe some context first, right? We know all of us have 5 senses. We have sight, we have smell, we have touch, we have hearing, and so on. But why are we all here in this session? We are so passionate about hearing, right? Why is hearing important?
Yes. So why is hearing important? I would say, first of all, let me introduce what is the hearing duty. As we all know that hearing started since young, since birth, and then it provides us the foundation for communication and social functioning. Just to recap for all of you, actually our ear is the doorway to the brain stimulation as well. And without hearing is actually no way you can develop language, and then you can also later stage, if you don't have language, you have to communicate with others. Next. All right. So just a recap, Karen, also to show all of you how we actually hear. A lot of people, they only relate ears with hearing, and then we rate the hearing part only limited to the peripheral hearing, which is the ear anatomy. But let's play the video. You can see that when we hear the sound, right, the sound will actually travel to the brain level.
Okay, could you see the video playing?
Yes, we can all see the video playing now. So at the end, the sound stimulation will reach to the auditory cortex, which is the brain area that is responsible to change all the sound stimulus to become meaningful sounds and also meaning to us. You may play the next slide. And then just also to let you all know why hearing is important, because it is actually one of our 5 important senses. As you can see from this picture, the blue line refers to the sensory pathway of the vision and also the hearing. And it all started just even before your baby is born. And then after that, it actually lay out as a foundation for the neural connections. And then after that, you can see that because of all this foundation of the sound stimulation in the brain, we can then develop our language. And for all the language, the stimulation all started maybe at the beginning of the age. And then you can see that around the 6 months old is the where it started, the peak. And then after that, it also becoming to develop the cognition function, the cognitive function as well. So if let's say everything like this, right, the human brain development, if we don't have the hearing, you can imagine all of these will actually skip behind. Meaning to say that, Karen, if we don't have hearing, right, sometimes the children may not develop speech at times as well, right? And then after that also, they don't have enough language, and this will also in fact will affect their academic performance.
So I think sometimes we do hear of cases where maybe parents have gone for newborn hearing screening. There's some cases of a hearing loss issue, but they take a little bit of time to seek further assistance, seek help and all that. But probably a lot of education on a slide like this to understand the critical important factor of getting hearing input into a child, which is a doorway to the brain, which you showed us earlier in the previous slide. It's so important. It's not something that should be taken lightly. And early intervention is important, isn't it?
Yes, true. Definitely true. As you can see from the next slide, actually everything started very early. And in fact, our language can be start as early as 6 months old. Then after that, we can also see that, can you click the next? Okay. And then after we have the language, then we will have the social skills. If let's say we don't have the social skills, then also it will relatively affect the person's cognitive skills as well. Because all these things is actually interrelated. I would say you must always have the language in order to have enough, how to say, I would say when you learn the speech, then you have a language. And then when you have the language, you can communicate with others. Then you can develop the social skills. And then after that, you can also start to learn from the teachers and then to develop your other skills as well. Yeah. So the golden age for the children is actually the first 3 months, first 3 years of the life. Yeah.
Yeah, we can see from this table, there's so many brain development going on, even from the first year, right? Binocular, emotional, habitual ways, and language is one of them for sure. And without hearing, there's no language development for sure. So in fact, I think even for the first year, it's also very critical period of time. Despite here, the study says that the first 3 years is important.
Yep. So, and then also to add on to let everyone knows that if let's say for this vocab development in infants, you can see the black color and the gray color refers to the normal hearing child. So Karen, do you mind to click next?
Yeah.
As you can see the chart, right? It actually the blue line refer to the language numbers of language expressive words that they can produce per day. But if let's say for a hearing lost children, or maybe we didn't know that they have hearing loss, right? Somehow their speech production is much slower. You can click next. This is actually the differences in terms of the numbers of production and also the rate of development. Okay.
Okay.
So the next thing can also see that if let's say based on WHO, this is not WHO, this is actually World Health Organization. They also mentioned that the impact for children who has hearing loss, if let's say leave untreated, the consequences will be as below, which is delay language development. Then the academic mostly is actually under performance, and then they also tend to isolate themselves from their peers because they don't have enough language, or maybe if let's say they also have some language but the speech production is not accurate, so they will feel embarrassed, so hence they don't want to they will tend to isolate themselves from the communications. And then also they will have higher risk for injury due to they might also suffer some balance problem and also increase property in long run. Okay, so do you mind to show my next slide? So hence the important message to pass to everyone here is that early intervention of hearing loss is very important. So in order for us to to actually have the intervention, we must first have the identification first. So there's a saying according to WCI, which is the Joint Committee Infant Hearing. They actually recommend the children should do all the newborn hearing screening by the age of 1 month old. And then by 3 months old, if let's say they fail their hearing screening, then they should already done their diagnostic hearing test. Then by 6 months old, they should already have any intervention. If let's say we follow this recommendation, the children may also have almost the near normal hearing development milestone, which means that if let's say we have early intervention, then it actually can reduce all the impact which I just described earlier. And this can actually make a big difference in child in terms of their psychosocial, educational, and linguistic aspect in long run.
I do know that in some countries, a newborn hearing screening is not compulsory as well. And sometimes parents are not aware themselves. Oh, I have to send my child for hearing assessment or for newborn hearing screening. So I think for those online on our audience, if you have a young child you have yet to access, then really, if you suspect of maybe suspicious of a hearing loss issue, then really it's important to get your child checked as early as possible. And there's a lot of awareness, but we have to do ourselves as well as part of this community.
Yeah, you can also get it checked in Sound Life. Okay.
Yes. Okay, so then I think we had a bit of context on early intervention, why hearing is important. But for parents, okay, if I fast forward a little bit, if they already found out their child has some sort of hearing loss, maybe they start to have intervention, they have some kind of devices, but could you give some tips today to these parents? Then how do they know their child is actually benefiting? How do they know they are getting good hearing?
Yeah, sure. So this is actually a relationship between audiogram and also hearing loss severity. As you can see from the colors, right? The green color is the normal hearing region. And technically, if let's say you have normal hearing, we can hear everything, all right? and then we don't really have much hearing difficulty. But if let's say your response is actually over the colors like blue or mild hearing loss, and then the orange color refer to the moderate hearing loss, and then the severe color the purple color, the purple color refer to the severe hearing loss, and the red color actually refer to the profound hearing loss. So if let's say you have any of these hearing loss, right, then the person may actually struggle to hear. Can you show the next slide?
Yes.
Oh, by the way, the audiogram actually refers to the graph where audiologists record the person's softer sounds that they can hear. Okay, in relation to different pitch. All right, the next slide.
So basically, better hearing, the report should reflect on a higher.
Example, how it affects if a person having the hearing loss. Okay. So over here, I also draw the line, the green color. So the one that below or the one that above the line, which is the normal hearing region. And then a good hearing, we normally say that they have good awareness of all environmental sound, which all the cartoon that you see over here, we all can hear. All right. And then the person also able to hear speech without repetition. For example, you seldom see them ha, ha, or even if you wear a mask or you cover your mouth, you talk to them, they don't really have any difficulty. And then in general, I would say less than 10% of hearing difficulty they will have. And then in the hearing impact children, which is like if let's say they wear the hearing aids or even a cochlear implant, their hearing aids should follow the language developmental milestone. Meaning like, for example, the first 6 months, then they will start to babble. Then after that, maybe about 9 months to 1 year old, then after feeding, then they should start to have their first word, then second word, then the third word. Of course, this one, the speech therapist can explain better lah. Okay. Can you show the next slide also? I have an example. So for a person who has normal hearing, this is the sound they will be listened for a bird chirping sound. Loud and clear.
Yes, can hear.
And then very sharp also. Yeah.
Yes.
All right. However, for a person who have this kind of hearing loss, okay, next. Which you can see, this person is having high frequency severe hearing loss. This is the sound here. Such a difference, right, Karen?
I think for some of us, we can hardly hear. I will play it one more time.
Can.
It's very, very soft.
It's very, very faint. The reason because the bird chirping sound is more on the high pitch, and this person is actually having hearing loss at the high pitch. It's actually at a severe level. That's why will not be sensitive to this kind of sound. So imagine if it comes to the wording, right? Oh, sorry, just now I forgot to mention the yellow color here. Can you point to the speech banana? This yellow color is the speech banana. Generally, our hearing response will be above speech banana. Then we can actually hear all the speech sound clearly. Okay. And then if let's say they are hearing loss, like for example, this example hearing loss, because it cut down the one at the middle pitch from 2000 to 8000 range, right? This person will actually have a difficulty to listen certain wording. For example, maybe when you say a word speech, they might hear it at speed. They don't hear the sound. Yeah. Okay, next. And this is actually example that for a person, how we understand the audiogram is any line above the one that we have plotted is the sound that the person cannot hear. So the grayed out area is where it's not able to hear.
So for a normal hearing person, technically, they should hear everything that's plotted on this graph. But for someone...
sorry, Karen, to add on. So they should hear everything in this graph, but also depending what is the actual hearing levels they have. We have found out from him lah. In general, although the normal hearing is below 20, but some of them may have like -10, some of them may hear it as 20. But this range, we are still categorized as a normal hearing.
And as per this audiogram, this person has a certain degree of hearing loss. Whatever is in this black color area is sound they cannot hear. He or she cannot hear, right?
They cannot hear.
And they're
So it's
missing
not
out
a
on a
good
lot of
result.
sound. Yes.
Yeah. As you can see, certain of the alphabet also they will be difficulty identify those consonant as well.
So for a person like this, even their pronunciation will be different because of the missing, like you say, speech. You can't hear the s and the ch at the end. So they say they may say something like that. In from the way they speak, you can also guess there's some hearing loss in this person.
Yeah. Yes. I used to identify a lady which is at her 40s. She didn't know she had hearing loss. But I said you should do your hearing test because I listened to the speech and I feel it's very accurate. So find out that it's true enough that she has about maybe mild to severe hearing loss, just like this graph. They may not aware that they can't hear certain sound because with effort they can still hear. And they always so one of the communication strategy they will require in if let's say they don't treat their hearing loss is that can you repeat? Can you speak louder?
Okay.
Okay. All right.
So now you can proceed.
Yeah. So why is it important for long-term follow-up for hearing assessment? Okay. As you can see from here, actually after hearing aid fitting is where we got our new device. All right. We start to have the intervention. But even though we start to have the intervention, we still need to undergo certain series of the tests in order to ensure the hearing aids or the device or even like CI is actually working optimally. So for example, real measurement is one of the golden standard of the test that we can identify the hearing aid setting and then it's under amplified or over amplified and then we can tune it to the optimum level. Optimum level meaning to say that at the end, we are actually trying to achieve near normal hearing ability after we actually fine-tune it. However, certain time due to when the hearing loss is too bad or when the device is having the limitation, the hearing aid cannot produce or cannot tune up to the level they're supposed to be. In that kind of context, right, maybe cochlear implant is actually a better option, especially for severe to profound loss. Okay. And then we also will do some other tests like aided audiometry, which is free field, and then the speaker produce a sound. The wearer is wearing the hearing aid while we produce the sound. Then we can actually record their response after they wear the hearing aids. So later on, I will show a few examples. What is actually when I define it as an aided response. Okay. Yeah. So this is actually one of the case study I show over here. The child was actually about 5 years old and then had a history of middle ear effusion. This was a case referred by ENT. And then after visited Sound Life for a few times because of the hearing reassessment, so the doctor finally give a line that, oh, okay, this child should be proceed with using hearing aids. So we have fitted the child with the power hearing aids. However, 3 months down the road, only we realized that even after fitted with the hearing aids, the child may not have adequate power to actually achieve a good hearing ability. As you can see, the one that circle on the right hand side, the circle, and then within the speech area, Karen, do you help me to point the line? That one is the aided response. The one below is actually the unaided response. The one upper is actually the aided response. But for this aided response, they still miss out a lot of the high pitch here, which is the sound over here. And this also refers that this also will cause the child not able to produce a speech sound, and it correlates with the parents' complaint, which is the child always not able to produce the sound or very clearly. Okay, next. And however, what happened after a few years later, 1 year plus later, we realized that the child also hearing dropped suddenly. So hence we do another hearing reassessment and we realize the hearing test result really getting worse. So for this kind of case, right, the hearing need to be readjusted accordingly. And then the hearing test, the hearing aided test was done again. And then we still see that the result not so good lah. Okay, so currently this child has been referred to for a CI consideration. So we have referred to the ENT surgeon lah. Okay.
So can we say for anyone, any age group, right, who's suffering from hearing loss, the deterioration can take place at any time. It could be sooner, it could be later, and it's important to identify or observe our loved ones, or be it children or being even adult, pick up all these signs and then still return to the hearing aid center or see the audiologist for long-term follow-up.
Correct. Yeah, you don't expect that one fit and that's it. You don't expect that because we don't know any point of the time. Even sometimes the earwax can be accumulate inside your ear canal, and then because the wear it for long hours, then the earwax is cannot come out by itself, and it can actually further cause the temporary loss because of that. And then sometimes it could be also the device problem, breakdown, or even like sometimes other things may happen like fungus infection and all this. So all this is like, as long as anything you feel is not right for your loved one, their hearing behavior change, they suddenly rub their ears so often, or even they suddenly reject their hearing aids, you should look for these are the signs that you should look for the audiologist. Okay. So this is the
second case.
This is the second case, but this is an adult. However, I just want to very briefly tell you, this is a case whereby this Mr. M is actually young adult fitted with 2 hearing aids. And this is the response for the unaided and also the aided response. As we can see from the graph, right, it's not too bad for him to perform in daily life. He can actually answer back and forth. Okay. However, what happened to him is that he struggled to hear anytime when people wearing the mask. He also struggled to hear anytime when there is a little bit of background noise. Hence, his life quality is limited. He always cannot go out with friends because he can't communicate with them outside the restaurant. Okay. Hence, after this, because listening to his complaint, and we did our best to fine tune the hearing aid, and this is the best result we can achieve. After that, we refer them to do a cochlear implant. So you can see that after doing the cochlear implant, the next slide, the right side has improved in terms of the hearing ability. And then the left side, however, still remain almost the same. So after, I remember Mr. M came back and then asked me, because previously he was fitted with another brand, which is not able to be, sync with the current CI, which is Cochlear brand. Hence, we loaned him with the GN Resound brand that is able to sync with the cochlear implant brand. However,
so just to clarify, because I think the audience probably didn't catch, Mr. M probably only got cochlear implant on the right ear, right? Not both ears. Henceforth, this result, right? Yeah.
Yes.
Only got it on the right ear.
You can see I noted that are both there lah. Right is CI and then left is the hearing aids. Yeah. Okay, so because of that, then I actually suggest Mr. M to go for second CI lah. And you can see after the second CI, and this is just few months, I think 2 months after CI for his left side, he can almost achieve near normal lah, which is the response between maybe 20 to 30. But for the left side, because it's still new, so it's still a bit lower. However, this is just to show everyone that if let's say you have noticed that the hearing aid device is not enough to cope with your current hearing challenge or need, then you should always look for audiologists and discuss about the option, how to improve your hearing. Sometimes the audiologists think that if let's say you have moderate and then your hearing is really not enough, we can recommend you some accessory in order to help you in certain situations. But sometimes if let's say hearing aid is actually not enough, then cochlear implant is one of the options. Yeah, that's all from my sharing.
Thank you, Aliyah. I think what I learned is hearing loss may be a disability, but it's really not the end of the road. There are many help or hearing solutions out there, which a lot of people are not aware of in the journey. That's why I think the audiologist's role is very critical. It's very important for patients to work closely with the audiologist, observe, go back for long-term follow-up. There's probably always a solution out there for each and everyone. So, but hanging there, Aliyah, I will bring you back to the stage in a moment. Meanwhile, I would like to introduce our next speaker, all right, which is Miss Shiro. She's from Speak to Me Speech Therapy Center. Shiro is the specialist speech language therapist who has a certification in ABT. So moving now to the speech development topic, I think Shiro, what we have received just now was a bit of context on the importance of hearing, early intervention, some of the hearing devices, support from audiologists. But this is really just the beginning. We all know very well. Without the speech therapy support and all that, this is not complete. And we will now delve a little bit into your passionate topic, right? So in view of that, how can you share with us, like, what does it really take for a child to have better speech development and performance?
Okay, sure. So usually in the first session, when I first meet parents who has children with hearing loss, I will always emphasize this too, because lots and lots of research have tell us these two things. You need good hearing and you need language-rich environment in order for a child with hearing loss to develop good listening and spoken language. So Aliyah have covered a lot about good hearing. Just remember the line at the top. We just want to make sure the brain can receive all the information in the graph. You keep sending all the good stimulation to the brain. And we also want to make sure that your child with hearing loss, they do not just hear when they wear hearing aids or the cochlear implants. Like, sometimes they'll say, oh, my child wear 5 hours a day, 6 hours a day, 7 hours a day. That is actually not enough. They need to hear 24/7, except when they're sleeping, of course, and also when they're taking bath. Because for people like us who doesn't have hearing loss, we cannot turn off our ears. And that's how all children pick up language. So they need to hear all waking hours. And language-rich environment, parents will always ask, what is the specific curriculum in therapy program? I would always tell parents, we don't have a specific curriculum. We use the built-in curriculum in your child's life. From the moment that they wake up, the things that they do first is to wear their hearing device. And then you start interacting with them. Things that they like to do, toys that they like to play, food that they like to eat, or the mess that they created, and how do you, do things together with them, and how can you talk to them, interact to them on day-to-day basis. So how can you interact with your child through daily conversations? And on top of that, you create specific playtime. It can be indoor, it can be outdoor, where you go to just a park, walk around the neighborhood. Those can be really good time to create a language-rich environment. And these two cannot survive without one another. If you want the child to speak well, you need to have good hearing and language-rich environment. Because if the child cannot hear well, you cannot send all the information in the audiogram that Aliyah showed just now. If you cannot send all the information to the brain, no matter how much you talk, they cannot hear all of them. They hear part of them depending on their level of hearing, right? And if you give them the most advanced hearing device, they can hear all the sound, but there's no input. Nobody talk to them. Nobody interact with them. They won't pick up language. Like, just imagine if you are going to learn Korean language, right? And you have good hearing, but no one speak to you in Korean language. You won't learn the language as well, right?
Absolutely.
So that is the foundation of it. So moving on to the next slide, I also want to highlight that for children with additional needs, when they have hearing loss and they also have other diagnoses, they have learning difficulties, they have developmental delay. On top of these two, good hearing and language-rich environment, they may need to also see other therapists, physiotherapists to work on their motor skills, occupational therapy, fine motor skills, attention, behavioral therapies, and all that, in order for them to develop listening skills and spoken language. And we also need to recognize not all children with hearing loss, they can develop spoken language. Some of them with very severe cognitive disabilities, learning disabilities, they might not be able to talk well. But with good hearing and language-rich environment and consistent therapy, they can develop auditory comprehension. They can understand your questions, and they can learn to respond to your questions, and they can learn to generate something with the other tools like pictures, like typing, to tell you what they actually want. So even though not all of them can get to the optimal results, but hearing plays a very critical role in developing the foundation to connect with other people. Yeah. And then moving on, just want to show this Hart and Risley research. It's a very old research, but it's very long-standing and important a study that gives us very good and important information on how children learn language based on how many language input that they receive. If you look at 3 lines here, the top lines shows that at 3 years of age, children who heard about 2,000 words an hour, they have more than 1,000 expressive vocabulary. They know more than 1,000 words by the age of 3 years old if they heard 2,000 words an hour. And if the child heard lesser words, like the second line, 1,200 words every hour, they speak less, they have less vocabulary, they know about 750 words. And for children who hear lesser words, 600 words per hour, they understand about 500 different vocabularies. I would say here, the average of children language development milestone, it's about the 750 words. But that means the more you talk to the child, faster they learn. They can learn more. Yeah. So this is very important information.
That's why with reference to the previous slide, you mentioned that it's important to expose them to as much sound as possible every waking hour.
Yes. Yes. Okay.
All right. So now understanding the importance of exposure to sound and all that, we also want to learn, probably our audience, that's why they are here today, to understand more how we can help the children to listen and learn. I think it's not easy, right? For children already with hearing loss, they have they see things, they hear different things, there's distraction and all that. Any tips for the parents on how to manage this better?
Yes. I designed this content based on some of the most important points that I always share with parents in my clinic. Because imagine if you want your child to listen to 2,000 words an hour from you, usually our kids will just ignore us. They don't want to talk to us. They just want to play by themselves. Most of the time, they listen half of what we say, right? So we have to think of how can we interact with the child so that they will want to play with us and they want to learn from us, right? So I know most of the time we have a goal in mind, like we want to teach numbers, we want to teach animals, we want to teach vegetable, but we also have to slow down a little bit, observe the child, and try to understand what is important to them. We know what's important to us, vegetable, animals, we want to teach that. That's important to us, and therefore we keep talking to them of what we want them to learn. But if that's not important to them, they're not going to listen to us. So I use this first picture as an example because most of the time for young children, when we take out a box and then we put some toys inside, and then we want to teach the child the toys that we have in the box. And most of the time, the kid team seems to be more interested in the box than the toys that we want to teach or to play with the child. So what do? Do we struggle with them? Like, come, look at the toys. Let's do this. This is bear. This is A. This is B. This is C. Let's stack it up. You can try. Of course, we can always try because we want to stick to our goal, right? And can be, you use animated voice and all that. But if all of that doesn't work because it's not important to the child, Then you have to think of, okay, now what's important to them? The box. What can I do with the box? Can I play open and shut with the box? Can I toss the box around? Can I slide the box to the child and let the child slide it back to us? Because children, young children especially, they love movements. They don't want to sit still. They don't want to put things nicely. They want to throw. So if you identify what's important to them and talk about what's important to them, they will want to learn from you. And also, the second picture, sunscreen. I don't know, I'm sure parents would know. Young children, they seems to be most interested in the most random thing at the house. Any simple container, sunscreen, phone charging cable. They like those things, you know.
The
Sometimes
weird
they
things.
think
Maybe
that
the TV remote control.
correct. The dust on the floor. So if they are interested in those little things, those random things, then you can think of, okay, that's important to them. What can I talk to them? What can I describe about the things that is important to him, to the child? There is a sun, and most often than not, children will want to open it. Depends, if you think you can open, you can, just let the child play a little bit and then describe the texture, then tell them cannot play too much, because they just want to know and experience. So sometimes don't be afraid to let them try something different and new, because brain responds to new information, interesting information, and it can create long-lasting memory. Or if you don't want the child to open, right, then you can pretend, cannot open, so tight. You help me.
So what I hear is that it's, I guess parents have to be very adaptive, very flexible as well.
Correct.
Apart from what they normally know or think they should teach their child, I think it's very normal, right? In the children's growing up years, the parents will be very kanchong and very excited to teach them certain things from the books. Maybe it's more academic stuff, maybe the words, the letters, and all. But actually, these things don't appeal to them. They lose
Correct.
attention. So if we see them interested in something else, how do we make the best out of that interest item they have?
Exactly. And the next tip that I want to share is, so you have identified what's important to them. Then what's new to them, it's referring to what are the new words that you can use with your child. For example, if they like box, right? So you can think of what are the words that is related to the box that is new to your child that you can use together with the keyword of box. Does the child know open and shut? If they know, then stop using it. If the child doesn't know throw or toss, if the child knows throw, then you can do toss. Toss the box. I toss it. You can try to toss. Do you want to toss? I don't know how to toss. So once you identify what they want, then you think of what are the words that you can use. If they know lotion, then you can teach them sunscreen. If they know yellow color or the sun, then you can teach them something else. Like it's something that, now this is a bit tricky. If they know the color, then you can say, I use it when we have to go out. It protects our skin. So it's always ongoing practice that not just your child need to do, but parents, therapists, we all do as well. Consistently challenging ourselves, That is why teaching the child, interacting with the child is not as easy as it seems.
Yeah.
And
The
it takes
parents
time to
are
practice.
the therapists to their child, and every day
Yes.
seeking new innovative ways to educate them.
And the next tip is, what is fun to the child, right? The next one, the next slide. Yeah. What is fun for them and also for you? Try to remember what you like to play when you were younger, and don't afraid to be silly, because when we play with children, we're supposed to be animated and fun and silly at times. So if you look at Geraldine in the middle, she was wearing the pomelo fruit skin as a hat. That's the best way that I could ever imagine to teach the child pomelo, because as you are cutting the fruit, the skin, and then you can describe the fruit, the smell, the texture, and then you can actually put it on your head. Children like things that is new to them.
Yes.
And it depends on your language input. So if you want to teach pomelo, fruit, wear it as a hat, it's cute, it's fun, it's silly, you need to keep using them when you're interacting with the child. Not just having fun, but having fun at the same time, provide language that is relevant to what the child is experiencing. That's how they will pick up the vocabulary. And the child might not repeat those words during that time. And that's okay, because you just want to have fun. Just imagine when you're learning, it's always about learning, and put yourself into the shoes as a learner. You don't like it when your teacher keep asking you questions. You like it when your teacher keep teaching you and telling you what to do. Maybe they tell you 10 different things and then they ask you one question. That's how you like to learn, right? You don't like your teacher to ask you 10 questions and then they only teach you 2 things.
And the process, they will
Correct.
want to learn when the process is fun, right? When we attend something, a class or something or training, it's more fun when your learning is more beneficial when there's fun factor in it. Yeah.
Correct. And it can create longer lasting impression, stronger impression, longer lasting memory of the word or language that you use together with the child. So next slide is about that we want the child to learn. So we have to teach. When you teach means you talk about the experience, you talk about the things you do, the things you see, the feelings that you are experiencing, but not testing. So you don't ask the child, what color is this? What fruit is this? What do you want to do? What is he doing? What number is this? Don't test the child, because the moment you start asking question, answer, that's not fun. It's only fun when we describe. That's so funny. Let's try it again. It's so difficult. Do you want to try that? You help me. They like this kind of interaction. Right? So focus on teaching. Don't expect the child to imitate everything during that time. If they remember, they will surprise you a few days later or a few hours later. So don't focus on asking them questions.
I think that's a great tip. Very often, probably in an Asian setting, Asian family setting, we like to use a testing approach, right, to teach the children something to learn. Make sure they remember, make sure they know, make sure they get the correct
only if
answer.
they can answer means they know already, right? Answer on the spot.
Yeah. So I think this point, I think with or without hearing loss issue, it's a great point where in the approach to learn or to teach children.
Yes. Right. I think we can move on.
Okay. So I think we understood clearly about how the different ways and approach of teaching or to attract the child's attention to listen and learn goes beyond what we know typically in a traditional approach. But how about the consistency? Just now you did talk about how it needs to come with variety, different way of interpretation and so on. Why is this important?
Therapy is habilitation for language, listening and spoken language is a very long process. It is not weeks or months, it's years. And I usually see a kid and support them for at least 1.5 years. Some of them goes up to 3-4 years, depending on their rate of progress. So it's important that when you go through this long journey, and in every step of the way, you know what is your goal and you know what you should do to achieve the goal, the listening and spoken language goal. If you have other, therapy goals with other healthcare professionals, you need to have a direction that you are moving forward to, and also knowing the goals as well as how can you practice with your child at home. And all this, it has to be consistent. By consistent, it doesn't mean, it's like classroom setting. You have to come into therapy, create a therapy room at home where you sit down with your child 1 hour a day. No. Sometimes not everybody can do that. Of course, if you can create a very conducive setting, that's all right. But what's more important is always go back to the built-in curriculum. How can you make the best of every little moments or interactions that you can have with your child at home? So sometimes, most of the time in our therapy session, I would, at the end of the session, especially for new parents, I would ask them, just tell me one thing that you want to practice with your child this week. We have practiced, we have, talk about different strategies, different goals, but sometimes it's just too many, right? So one thing from mommy and one thing from daddy. So they just know one, and then think of how can they practice this at different activities in their life. For example, if the child will say, oh, I saw the police car. So the mom would say, okay, next time when I was in the car, I would use this phrase with the child. I saw big lorry, or I can see a police car drove by. I can see this and that. So identify the word or the sentence that you want to introduce to your child, and think of the daily activities that you will do with your child. You will fetch your child to school. So in the car, what can you talk to your child? What kind of conversation you can have with your child? So do it consistently is very important.
So for a goal and action plan like this is something that parents could possibly work with you in your
the
profession,
therapist.
right?
Correct.
Okay.
And moving on, I want to share this because, again, it's a long process. It's a long journey. And every child progress at a very different rate, different pattern. Of course, we want the first graph, first chart, smooth sailing, slowly going up. But it doesn't happen to everyone all the time. Sometimes the progress can be slower. Sometimes there can be a big leap of progress, and then suddenly the child doesn't seem to use as much word, or when the child pick up a new word, then the child stop using other words that they have learned before. And that's all right. That is all right, because as long as at the end of the day, you see that the child is moving forward. So it's important to check in with the therapist. We're moving to the next slide. Consistency also means you talk to the therapist consistently every 3 months, every 6 months, review progress, because sometimes this week the child very cooperative, next week doesn't want to do anything at all, the next following week okay for the first half of the session, second half don't want to do, or just want to do one thing. So parents will always say, today not good, last week was very good. I would always tell parents, even for adults, we have good days and bad days, good weeks and bad weeks. And it's actually very normal for children to have that as well. We cannot expect them to perform, perfectly in every session. As long as the child is moving forward in terms of their language skills, that is what we want. The child doesn't have to be, very polite and listen to me all the time in the therapy session. So ultimately, review progress, and also when there is a slow progress, what can you do differently? If the progress is really very slow, or it has been the same, no change at all, what can you do differently? Discuss with the therapist.
I think for parents, they should not feel alone in this journey. There are families out there who are facing the same challenge, and they are also help like yourself, like be it audiologists, be it the speech therapists and all that they can seek support from to understand how better to cope with this. But not every day is going to be consistently upwards trend of improvement, right? So I think I think it's very encouraging to know that consistent is key in what they're doing. So I understand you may have a case example to share with us now.
Yes. I want to share with you a case example of Damien. Damien is, I think he's now 9 years old. So this video was recorded in December 2019. He was born with bilateral profound hearing loss. He does not receive very early intervention. He only received bilateral cochlear implant at the age of 3 years old. It's like at the age of the golden period of language development. But he had very, very strong and consistent family support. I cannot stress this enough, because I know I journey with them, and I know how much the parent have put in to support his learning. So he received implant at the age of 3 years old. And I remember I always tell parents, keep telling them, reminding them that we actually don't expect a very rapid progress in his development because he does not receive very early implantation. But he surprised me. He surprised me. He used CI for 2 years, and when he was around 5 years old, he was able to have simple conversations. He can read the sentences, you can see in the video, but his speech was very, very unclear. He only have vowels A, E, I, O, U, and he only have the consonant So, for example, he can only say ma, but he cannot say pa, he cannot say ta. It will all sound like ah. So I'm gonna share with you a video of him reading, because at this point of time, he was only using implant for 2 years and he can read many Chinese words and sentences, but his speech was very not clear.
So this is the first year.
Yes, this is
In
the
his first year,
This is the first video. Second year of using CI.
second year of using a cochlear implant. And let's hear from Damien.
Yeah. The yeah.
在
I yeah. Yeah. I yeah. 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 Đến ồ I yeah
上
ow
So then we conducted motor speech assessment and we found out that he has apraxia of speech and also oral motor difficulties. And I referred him on to Kapeng for oral motor assessment as well as therapy. And this December 2019 is just before COVID hit us. So parents, they didn't let this, pandemic thing stop them from moving forward with the child. They contacted Kapeng. I referred him on to Miss Ukapeng, contacted her, and then they started online therapy session for a year, the whole of 2020. And the next video that I'm going to show you is him reading the same passage a year later.
第5课，大家上山。大人在家，小孩也在家。大人上高山，小孩也上高山。大家
That's a huge improvement.
Right. You can
Yes.
almost hear all the consonants coming out nicely, and it's also more fluent.
Yes. And confidence.
So monitor progress, discuss with the therapist if something is not quite right, and identify what else can you do, or how can you do things differently with your child. Do not give up.
Yeah, but I think some parents may not know there are options as such to also correct in terms of his oral motor therapy part of things. And we've seen here, this is a living example in just 1 year get that kind of improvement in his articulation and pronunciation.
If you listen from the parent first, right, they will share with you the struggles, the things that they had to do to negotiate with him in order for him to want to do the practice with the child consistently. It's a lot of hard work.
I think apart from giving these children with the correct hearing devices, technology, the next phase of therapy, parent involvement, being flexible, being very much involved and willing to understand or take on new approaches as such is very critical. I think parents together with the healthcare professional like yourself play a very big role in ensuring the success of their speech development.
Yep.
So thanks so much for sharing this very good example with us.
My pleasure.
Okay, so with that, I will have Shiro to wait on the slide for a moment. Thank you for this very beneficial lightning session. And I'll be inviting Miss Okaping, who is also from Speak to Me, and she's a specialist speech language therapist in pediatric feeding and swallowing. So very appropriate time to introduce you now, as we just covered a case study which involved your involvement and your expertise.
Yes.
I understand, through some prior conversation with you, that there are studies, many studies, in fact, that have shown that 40%, a whopping 40% of hearing loss children are actually found with additional diagnosis of disabilities. And for me, this is quite a shocking number, and it's relatively high as well. And for children, who has gotten all the hearing devices they need, gone through speech therapy sessions and all, how would you, on this session today, share with the parents how to identify if they have additional signs or observation of the child that they need to do something different from the typical route?
Okay, thank you, Karen. So I'm Kaping. I'm specializing in feeding, oromotor, and dysphagia. So my role is to actually look into the facial movement, the facial components, like looking into the mouth, looking into the lips, looking into the cheeks, looking into the facial expressions, looking into the tongue, and the jaw movement while the child is eating and while the child is talking. So that will give me a very good example and give me a very good, valuable things to actually look into how they use their muscles correctly. So let's look into this. What is oromotor skills? So, and we will need to actually understand what is oromotor skills. Oromotor means like is appropriate use and functioning of facial muscles. The facial muscles include like jaw, lips, tongue, the cheeks, and the palate. Okay, so these are all facial muscles that we use when we talk. Even when we actually make expressions like sad face, like happy face, and then angry face. And all these facial expressions needs facial muscles movement. Like what Karen has actually shared, like we do actually have 40% of the hearing impairment children actually have additional disability. I mean, like something. So that is one of the thing is like the facial muscles are not acting and not being used correctly at the early stage. All right. So like some of the children, they are not able to actually wink, like do this. So that will be actually tell us that the child is not able to actually use the facial muscles. As we see in the diagram over here, there are so many muscles that are actually involved to actually make certain movement. So if I would like to actually just use like smacking, kissing, then I'll use my orbicularis muscles over here like. So there are actually movements over here. If I want to actually say I need to actually put my jaw down. And the muscles over here are being retracted longer. So, and then if I want to actually say like ta ta ta, then I'll be able to actually use lots of my tongue movement and my jaw movements to actually move. So these are the things that lots of actually muscles has been used. Beside the muscles are being used for actually talking, these muscles are being used for chewing, for eating. So that's what the facial muscles are. And the coordinations of all the muscles are working together to eat. And all the muscles together to actually talk. So that's the importance of how we need to actually identify whether our child or our children have muscles issues that is actually contributing them to actually have feeding, eating, and talking issues. So let's move on to the next stage, the next page, which is what happened if our muscles are not functioning. Yeah, so what happened if my orbicularis muscles, my lip muscle is not working well, if my cheeks muscles is not working well, And if my jaw is actually not functioning very well, so what would happen to us? All right, so let's look to the next slide. Drooling. We will see our children have drooling, and then you will see like 4 years old, 5 years old are still wearing beep, and then like lots of drooling. So when they talk, lots of saliva are actually spraying out. So drooling should stop by 24 months old. So if above that age you still have drooling, it's a sign and symptom of a child who have actually oral motor skills issue, or oral motor problem, or oral motor disorders. All right. So, and then not able to imitate funny faces and oral motor movement. Like if you ask, like when usually like 3 months old, 4 months old, when we play with our children, we will be like peekaboo, and then we'll be like doing some funny actions. But the child is like just looking at you and not able, and there you know that he or she is trying to like copy the facial muscles, the oral motor movement, but the child have difficulties to actually imitate. So that gives us a very a sign, like indications that probably my child have like some imitations issue, and then perhaps that he or she cannot actually move the muscles, the facial muscles very well, or perhaps that the cheek muscles are actually weak tone, very low tone, that is not able to actually use the muscles correctly, or sometimes the lips or the jaw or the child is actually a mouth breather. A mouth breather means that the child opens the mouth all the time, like breathe through the mouth and not using the nose to breathe correctly. So, and snoring at night. So a child or whoever that we are snoring, adult snores too, but it is actually not normal things to actually say that snoring is normal. That's never a statement to say that snoring is normal. It happens to a child like 3 months old, like breathing very heavily, which shows that the tone of the muscles is actually very weak, and the tongue falls back to the throat. So it actually blocked the airway. It caused the snoring. So it already shows us that the sign of symptoms of actually muscle weakness, or not able to actually blow bubbles, like lip rounding, like to blow the bubbles. A lot of parents, they say that, oh, my child can blow, he can blow very well. But when I actually ask the parents, show me how does your child blow, and the child blow, or when they blow, it's lots of salivas coming out. So it actually shows that the lip muscles and the jaw muscles are actually not working together to actually create a correct tone to actually blow the muscles. All right. So the lips, it shows that the lips already gotten a problem. So then it will actually cause some difficulties to actually produce the O sound and the U sound, which is the open. Like if you blow like this, how do you say open? Open. So we don't say open, we say open. All right. So if our lips have issues, that actually going to cause some difficulties in clarity. So not able to lick. The tongue is actually having a weak tone, and then having troubles to actually move forward, to move left, right, up. So it will actually cause lots of issues with speech clarity too. For example, then when we need to actually say L, we need to say N, we need to say P, we need to say B, we need tongue. So lots of our children who has difficulties to actually do licking or tongue elevations, means that tongue to push up, they have difficulties to actually produce speech clarity of L. They will say, oh, pop. It's besides of lollipop, they say, oh, pop. Or they will say, oh, lollipop. They will try to actually miss some of the sounds. Okay, so we go to next page. All right. So let's talk about the jaw and then the facial expressions. And besides having the other issues on the first page, and if we have jaw issue, we are not able to actually chew our food. Let's say that our jaw is actually very weak and doesn't have strength So if I give a piece of chicken to the child is not going to actually use the jaw muscles to chew. Besides, they are using a lot of tongue thrusting to eat. So with these jaw issues, it may actually cause issues of the child being picky eater later. Means like, I wouldn't want to actually take any hard solid. I would like to only take milk. I would like to actually only take blended diet. I would like to only take meltable food. Meltable foods is such as like biscuits. You need only 2 or 3 chews and it melts in the mouth. And then after that, you like chickens, you need 15 to 20 chews. Like we never imagine that we counting this, but for a therapist, feeding therapist, we do count. Like a nut, we need about 20 chew or 5 chew. Some are like cashew nuts, we need more than actually 10 chews to actually make that nuts to become soft and to be mashed so that you can swallow. We can't swallow one piece of nut. It's going to cause choking on our children. So that's the reason why we need lots of jaw movement and strength. So, and then if a child who is taking 1 hour to finish the meals, is going to actually take lots of hazard and lots of actual difficulties to the parent. And it did actually shows our child may have actually oral motor skills, which is actually the jaw weakness, the tongue issue. So what does it imply? It may imply the child will not be able to actually imitate the correct speech sounds, not able to actually use the correct muscles to actually speak correctly. So like Damien just now, like he was not able to actually use lots of consonants because he is only using lots of vowels, so lots of actually because of the tongue muscles is not being used correctly, the lip muscles is not being used correctly, and the jaw muscles are not being used correctly. So we need to actually do therapy on jaw muscles, lip muscles, and the tongue muscles to actually make the muscles to be getting stronger and to teach the child to actually blend those muscles together to make words, to make sentences, and to work on chewing. Yep, so we go move on to next slide. All right, so we need to actually look into the red flags and understand about the relationship between the oral motor and the feeding and speech. And I could not emphasize enough, like just now, the importance of oral motor skills in eating and talking. So, but how does it actually affect us? If you look into the chart, so like at the early stage, like 0 to 3, 3 to 6 months old, we are only taking bottle feeding, taking breastfeeding. So when we are actually taking breastfeeding, it's an oral feeding, like formula drinking, like milk bottle and breastfeeding. So what does the baby do with the jaw and the lips and the tongue? So the lips is actually sealed onto the breast or sealed onto the nipple, the bottle. And then after that, the jaw will actually move to actually suck the milk bottle. And then the tongue is going to cup to actually withdraw the milk from the milk bottle. So that's already give us a very good indications of how a correct muscles is being used from 0 to 6 months old. If a child who has tongue tie, all right, if a child who has weaknesses, a prem baby, a premature baby, who are not able to actually use the muscles correctly, and then is actually going to have sucking issues, is going to have milk bottle issue, and is going to actually have feeding issues. And all this correct movement of the jaw, lips, and tongue at the early stage will actually help us to actually create ooh sound, oh sound, because we are sealing on the breast, we are sealing on the nipple, all right? So when 6 months old, we start actually solid. We are using the spoon, all right? So when we actually eat from the spoons, then we need to actually just like withdraw the fruit from the spoon. So that actually helps us with lips muscles to actually strengthen our lips. It helps us to make the M, B, and P sound, all right? So when we are drinking with straw and we are drinking with spoons or we're drinking with cup, so imagine that you are drinking now and consistently your tongue is actually moving backward. So that's going to actually help us to make the K and the G sound. All right. So if a child who is actually constantly using milk bottle and 24 months, 36 months, how does the tongue actually being manipulated and being trained to actually being retracted to actually train for the K and the G sound. All right, so like that using the fork, spoons, and all those things like towards about 36 months. So all these are actually solid feeding from a milk liquid to puree to solid. So it will help with all our jaw muscles, lip muscles, and tongue muscles. Yeah. All right. So the next slide. All right. So if you can see, this is that I know that is a bit small, but it gives us an indications of like if our jaw is actually moving open. All right. So it helps us with the R sound. A, R, K, Ka, Ga, Da, and then all the sounds. If our jaw is able to actually move into a middle position, it helps us with that E, right? E, K, K, and then all this. If we are moving to a very small movement of our jaw, it helps us to make me, moo. So it helps, the jaw is actually helping us to actually shape our mouth, to shape our lips, and to shape our tongues to actually talk and eat properly. So all these are actually indications of oral motor skills that are actually needed and to help our children to actually speak and eat safely and nicely and using the correct muscles. So we have actually shared like if the muscles are actually not being used correctly, are not being produced, not being functions properly, so it does actually affect eating and talking. Yeah, so at conditions called apraxia, dysarthria, and all sort of actually oral motor disorders, all those diagnoses, but we are not going to confuse the parents with all those diagnoses, but we are just sharing like it could, yeah, affect the speech and the feeding disorders. Yeah. So over to you, Karen. Yeah.
Thank you, Kaping. I personally feel that your sharing was very enlightening. There's a lot of new information, education for myself as well as I think the audience who are still joining us live right from the beginning until now. Probably in one session like this, it's not enough time for you to further, illustrate or justify all these tips. I think you are really just giving us like the surface of what's so much more to come. Thanks for sharing that with us. In fact, we always thought that with the use of technology, with the standard speech therapies, all that, maybe that's as much as we can go with telling the parents what to do. But now today, I'm enlightened as well with the oral motor skills. How we use our muscles. I was just imitating you as well with every word you were trying to say, and I realized, yeah, we're using our jaws and upper lip and all that. So it's very, very interesting for me, and I'm sure for the audience as well. So thank you so much for giving us a sneak into what is it about with oral motor, and with Damien's example, how your expertise helped him in better pronouncing all the consonants and all that. So I think that was great. I'll probably now just wrap up a little bit on the talking points. We managed to finish all our presentations with the 3 speakers today. And to our audience, thank you for still hanging around. I could see there are some questions over there. We'll go over there in a quick bit. I'll just wrap up a few of the talking points from today's presentation. Right. So from the start, we heard from Aliyah, and we understand that the long-term assessment and upgrade of hearing solution is necessary, I would say, or as well critical to ensure better hearing outcomes or performance for patients with hearing loss. And she has advised as well, as a rule of thumb, usage of any hearing devices should be more than 8 hours a day, and eventually increasing to all waking hours possible for a hearing impaired patient. And also from Shiro's session, we understand that to ensure positive outcomes, children with hearing loss needs good hearing and consistent practice. I think we couldn't emphasize enough. A lot of notes we have taken from Shiro about how we all should be very flexible and adaptive to encourage learning as well as consistency. And intervention takes time and patience. We saw how progress can mean a steady upslope kind of trend. It could also mean up and down trend as well, but everything is considered progress. I think it takes a lot of effort from the parents for sure, but with persistence, with patience, I think they will reach their milestone and their therapy hearing goals. So reviewing the progress, making changes, so you're satisfied, you're not satisfied with the current process, it's possible to talk to your speech therapist. And just recently, we heard from Kaping, the correct movements, functions of oral motor skills are actually the foundation for feeding as well as good speech. And I think that was definitely very enlightening for us. So with that, I'm going to bring everyone back onto the screen now. If I can add Aliyah and Shiro back here. So thanks for waiting.
Hi.
Okay. And we'll probably go into the Q&A session now, right? While I was hosting, I could see some questions popping up and down. We'll try our best to answer. If there are certain questions that may require additional professional input, we will advise as such as well, and happy to connect with you or to refer you to the right professionals for further discussion, right? So I'm going to go with the first question. It's a little long. I'll try my best to read it. If not, I think there's a next to it. Probably it's cut off. From Gyok Ping, right? My son's hearing test on the right ear is normal. Left ear from mild hearing loss, both under the category type B. After visiting a government hospital, it was recommended to have a grommet procedure due to the last hearing test with mild to moderate hearing loss. And a recent hearing test showed there's normal to mild hearing loss, so the procedure can be postponed depending on the parent's decision, since there's no urgency to proceed with the procedure. So far, my son has language development. So I think the question got cut off. If Gyoping, you want to finish off typing, you can type it now. She probably wants opinion. Let me see, if she has started typing something below. She wants an opinion about something, which the question got cut off. I'm not sure for my guest speakers here, if there's anything to add on, or what do you think, if you can guess the question. Otherwise, I'll come back to Gyoping when she finished typing her
I think she
question.
probably asked if they really need the grommet procedure.
Okay.
Yeah, I think this is a common questions that people tend to ask, whether my children needs a grommet procedure. I would say at the end, it's actually depending on the result we obtain. Through the tympanometry test, we can actually tell whether the medial ear effusion already subside. Sometimes it can be controlled by medications, but if let's say the medial ear effusion still there, they still obtain the type B tympanogram, and doctors have tried the medications and still not still not treating the things well, and the medial ear effusion has caused some hearing loss, I will propose to have it lah. But however, the final decision should be actually advised by the ENT surgeon.
Absolutely.
Yeah, because at the end, we also recap back the good hearing. Anything that you started to hear lesser, even though it's a mild hearing loss, they will also affect the children's attention to learn things. Because when the sound is not loud enough, then they cannot really pay attention that well, or even like they can't hear those like distant speech. Because when they learn in the school, sometimes the teachers stand quite far away. So good to have lah.
Any other input from the panel here?
I just want to ask another follow-up questions. Let's say if the child has type B tympanogram result, right? And then after a while, it becomes A, becomes okay. And then after a while, it's always recurrent, always coming back and coming back and coming back 2 to 3 times a year, sometimes more. So is that also like a stronger supporting factors, that it's an indication, okay, maybe we really should go for this procedure?
Yeah.
Compared to if it happens once and then becomes normal and then it doesn't happen anymore.
Yeah, I think these are all signs or observations to be made.
Actually,
Okay.
there is a research. Sorry.
Go ahead.
So there's a research. There's a research suggests that if let's say there's a recurrent middle ear effusion or any conductive hearing loss happen longer than 3 to 6 months, actually action should be taken. The management of hearing loss should be taken. Otherwise, it will have the impact on the speech and language development, especially for children.
Okay, but nonetheless, I think we've also highlighted it's still good to get a input or professional advice from an ENT doctor at the same time.
Yeah.
To
Correct.
confirm this. Okay, thank you. So we still have a couple of questions. I'm going to move on a little quickly. This next question is from Catherine. She asked, what if the kid has 98% profound hearing loss? The audiologist told us nothing they can do. So probably we get the panel to give their 2 cents worth.
Okay, so I think 98% refer more on the profound hearing loss. So for these questions, it's just based on the question 98%, then of course we can try with the superpower hearing aids first. But if let's say after try with the superpower hearing aids and it's still like not much response, then cochlear implant is one of the options to improve lah. Because we have to understand the etiology that why the person cannot hear. And most of the time, profound hearing loss is due to the cochlea is underdeveloped or even the cochlear damage is too much. So, or even the nerve is having the issue. So if let's say it's due to the cochlea, then hearing aids sometimes already reached the capacity, then we cannot really help with the hearing aids.
Yes, I think Catherine did add on later in the message box that the child was wearing hearing aid, but there's no response. So I think you've addressed that. If even the most powerful or high-power hearing aids have been trialed on the patient and they're still not working, cochlear implant may be the next option. Of course, you still need to consult the ENT. You need to do MRI, CT scan to confirm a patient is a good candidate. Should they mention later the kid couldn't go for cochlear implant as the kid has trachea. So that's maybe beyond my personal expertise as well. And we may need a ENT professional to advise what are the other possible solutions or options. Okay.
Yeah, sometimes they will require the multidisciplinary, not only the ENT handling the surgery, but together with some of the other expertise like pediatricians or other surgeons, which is more expert in this area, just to ensure that the patient's condition is still safe and well throughout the surgery process.
Okay. Then I have another question here from Shi Pei. Her 3-year-old likes to put things inside her mouth. Is this normal and what can we do?
I think this should be a question for Kapeng. But what I can say is for 3 years old to put things in their mouth is definitely not normal.
Yes, hi. Not sure whether you guys can hear me because my line is a bit out.
We can hear you, but you froze. I think your screen is froze.
Okay, so yeah. All right, so for a 3-year-old, we don't actually quite see mouthing now at this moment because it's because the child already gotten enough stimulations from eating throughout from morning to night. All right, so the oral motor functions should have actually gotten enough stimulations and the oral motor skills are actually fully developed. So if putting things inside the mouth, then we need to actually see whether is it because of the airway issue that is actually blocking, got tonsils, got adenoids. So they constantly need some chewing to actually clear in the hearing or lots of actually how would I say it? A lot of actually additional factors that we need to actually look in. So if a child who has not gotten additional problems with hearing and then doesn't have other problem with actually oral motor muscles, so a child should not actually have mouthing stage at 3 years old, that I would say.
Okay. Thank you, Kaping, for the comment. So what can Shi Pei do about it if this is not a normal
Okay.
behavior?
So yeah, so we need to actually take in an assessment to actually find out lots of actually details by actually asking a lot of questions and then looking into the muscles. Then only we will be able to actually find out the cause. Is it because the child's actually mouthing towards during the child is stressed, or mouthing towards when the child is actually about to sleep? So if like about to sleep or during sleeping, that is actually quite confirmed or is connected to the airway issue. And it is actually like a lot of mouthing when the child is actually being asked or being put on stage to actually like talk on something or put on the spotlight. Then she got stressed a little bit. Then after that, she do lots of actually mouthing strategies to actually ease the sensory issues. Or a child who has actually let's say teething, but it shouldn't be, because like 36 months old and above, we already stopped teething. Yeah. So that we need to actually look into lots of actually additional factors. Yeah. So to actually find out what is the cause first, because like if like I would just say that 3 years old should not have actually mouthing, but what causes it and how can we do it? We need to actually find the cause first by asking lots of actually questions. Then only we will be able to actually find out, is it a muscles issue? Is it a habit issue? Is it a sensory issue? Then we can actually do the suitable therapy on the child.
All right. Noted. I think that was very comprehensive advice from Kaping. I hope that helped you, Shupi. And then I think we have a last question here. I actually cannot see the question, but I may have to guess that is a question. From Pang Li Yong. I presume is that. He says, my 3-year-old sometimes snore, depending on how tired she is, sometimes depending on the sleeping posture. If she's very tired, she snores. She sleeps with high pillow or sleep in the car seat, she snores too. There's no question there, but I think this is probably linked to Kaping's session earlier on oral motor skills and how snoring, all these are signs. So for a 3-year-old, is maybe I help him to ask the question, is it something of concern? What advice would you give? I believe it's Kaping's topic here.
Thank you, Karen. Yeah. Okay. Snoring is never normal. Yeah. So it's not a normal behaviors to actually snore for all of us, for even for babies until adulthood. So if someone snoring, so it shows that the muscles are actually having some issues, especially we are looking into the tongue. Especially if the tongue is actually falling back, it will actually cause vibrations, then actually it snores. All right. So if like the parent says that, okay, during like tired time that it snores. So during tired time, the muscles are actually all relaxed and all very tired. So there is not tone enough. So we do actually snore, but if the breathing is actually, the airway system is actually being disturbed, prolonging of actually snoring actually cause us to actually have lots of actually indications of the airway is actually compromised. All right. So, and the tongue is actually falling back. So we will need to actually look into the oral motor muscles and to check out what are the main causes that is actually causing the snoring. It could be because of mouth breather and the low tongue posture, and then it could be because of the tongue tie issue, and it may be because of the posture issue. There are lots of actually factors that are actually causing snoring. The most important thing is that we need to actually find out the factors and make sure that it doesn't actually cause sleep apnea. Sleep apnea is actually sudden wake up, holding for breath. So yeah, it's actually a danger to a brain. Yeah. So I'm not actually trying to scare all the parents over here, but actually like it's just an indications or symptoms that our child needs help with the oral motor skills. Yeah. Over to you, Karen.
Thank you, Kaping. I think that was insightful as well.
Hi, Karen. I would like to add on also. I think if let's say you always have the snoring issue, you should also seek ENT help as well. Let ENT to have a thorough checking to the nose and also to the throat area, because that is a related area.
Airway system. So it could be adenoids, it could be tonsils, It could be the tongue. It could be the base of the tongue is actually falling. So we always actually refer to our ENT, pediatric ENTs or adult ENT, just to actually look into the structures, look into the anatomy. Yeah.
I think for a lot of the questions and topics we have discussed today, it does involve the multidisciplinary approach. Yeah, not just one type of discipline to assess as well as draw some conclusions from that. So I think, I think we managed to cover that. And I think we come to the end of the Q&A. We managed to cover all the questions. And thank you so much, everyone, for still hanging around. I still see 40 over of you online. And I will now, without further ado, I will now move on to the quiz. So there are just 3 questions because we are looking for 3 lucky winners. Okay, basically it's a very simple quiz. 1 question from each of the presentation that's been provided by our speakers, our panel today. And the fastest and correct answer that is posted on the comment box will be selected as the winner. And I will put up the information there on how you can contact us to claim your prize. Okay, so for now, everyone, all our audience, fingers, keyboard, stand by. Okay, I'm going to flip on to the next slide where you can see the first question. I'll read out to you. And if you are confident of the answer, please type it out on the comment box. Okay, the first question here is, under which circumstances should you, or as parents, bring your child to revisit your audiologist? Is it A, when the hearing devices are faulty? Is it B, when your child's birthday is approaching? Is it C, when you realize your child's hearing behavior has changed? Or D, when your child complains about discomfort, for example, always rubbing, touching their ears? This is a question with multiple answers, okay? That's a tip for you. So type in, okay, I see everyone has typed in really quickly, but most of you have chosen only 1 answer. Okay. I'm going to say one more time. This question has multiple answers. So if you think it's ABC, BCD, or CBA, type all the 3 letters in 1 answer now, okay? I start to see the first answer with C and D. Someone says C and A. Not yet. I don't think. Okay, wait. I think I have seen the first answer. Tei Shi Ting. Am I right? Aliyah, did you try to catch?
I think Leonard.
Is it Leonard?
Ong.
Is it Leonard?
Yeah,
Leonard.
early.
Sorry.
Yeah,
You guys are
congratulations.
really fast.
I guess I come out the very tough questions.
It's like a trick question. Okay. Yeah. So, okay, Leonard, congratulations. You have won the prize for the first question. And I will probably get you to step back and let the others have a chance with the second and the third question. Okay. All right. We still have a chance for the audience. Are you ready for the second question? Here we go. Second question. What can I do so that my child will want to listen and learn from me? This question is from Shiro. Shiro, this is 1 answer only, right? Or is it a multiple? Oh, there's also 3 answers. Okay, think, everyone, please be careful. 3 answers. Is it A, use new words with the child regularly? Is it B, observe and follow my child's interests? Is it C, always ask them questions? Or is it D, do fun activities with them? I'm going to imagine all the answers popping up very quickly now. So, Shiro, you may want to look out for the answer.
I think it's Romano Gola.
Romano, the answer is A, B, and D. Use new words,
Yes.
observe and follow child's interests, and D, do fun activities. All right. Congratulations, Romano. So, okay, I think so. Just after Leonard. Okay, we have our second winner. Any comments? I think this is pretty straightforward from Shiro. If you were listening to her, you were paying attention, this will be a no-brainer. So congrats. Now, are you ready for the last prize? Okay, the last winner. Last question I have. This is coming from Kaping's session. Ready, go. Do oral motor skills affect eating and talking? I think this one is a giveaway. It's a yes or no answer. Okay, do we have questions? Do we have answers already? Do oral motor skills affect eating and talking? Is it yes or no? I think we've got the first response.
Yeah.
Was
Nurlis
it?
Azman.
Yeah, Nurlis Azman, right? Kaping, am I right? The answer is yes.
Yes, correct.
Hey, thank you, Kaping, for the question. So I think it's quite nice to see everyone so participative in this at this hour, 10:40 p.m. on a Friday. Thank you so much. I think we have got 3 winners here as well. Appreciate your participation. And that's right. For all the winners, please email us at ego@cochlear.com. My colleague will be helping to process the prizes with you. Okay. So take a snapshot of this email address, ego@cochlear.com. If not, I will leave a comment at the comment box later in case you need to refer. And I'd like to thank our speakers today and the collaboration from Sound Life as well as Speak to Me, Shiro, Aliyah, and Kaping for staying up and putting time together to prepare this. Took us many hours as well to put this topic together. If the audience has other questions or even you think there's a possibility to come back for round 2 in the future for more specific topics, do leave your comments and feedback on the message box. We will refer to them and probably hope that there's opportunity for us to collaborate and bring more information, awareness, tips as well to you. All right. Thank you so much, everyone. I will not keep all of you. It's really late. We have overran by a little bit, but I think the participation has been great. Any closing statement from our comment from our panel here before I close the session?
I just want to say I am very, 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 very impressed that, most of our participants stay with us until the very, very
I
end.
know, right?
Now we still
Yes.
have 38 people.
I agree. I was worried.
Thank you so much. Thank you so much. And I think feel free to drop us questions or anything. We will be really happy to listen to your questions and design the future content based on your concern. We want to be able to reach to more people and provide more information to more people through event like this.
Yes. I think it's a very big topic we covered today in just in 1.5 hours. There's so much more. I hope all of you had more case studies to show with us to understand real life how these approaches, techniques as well as tips are being used on the patient. And I think with Damien's example was very, very impressive how a combination of multidisciplinary has helped him. I really hope to see more stories as such in the future if we can, right? Okay.
Sure.
Anything else for Aliyah? Kaping?
Not from me.
I would say very thank you for this collaboration with Cochlear and also Speak to Me. I myself personally also learned a lot from Shiro and also Kaping. Yeah, thank you.
Thank
Same
you,
for me.
everyone.
Thank you,
Thank you.
Kaping. Thank you,
Thank
Kaping, Aliyah and Shiro, and thank you for everyone that's still online now. Hopefully we have a chance to meet again second session also, hopefully. Okay, have a good night, good evening,
night.
and good
Good
week.
night. Bye-bye.
Bye-bye.
Bye.